All right, last section, we're going to talk about dementia. And dementia is sort of an umbrella term for cognitive disorders that includes several different diagnoses, which we will talk about. But it involves a loss of memory and other thinking abilities that are severe enough to interfere with your daily life. So people have different cognitive ups and downs during their lifetime, but whether it's dementia or not is if it's severe enough to interfere with daily life. So, same learning objectives that we had in the previous sections, but just for dementia. So, the definition of dementia is a decline in cognitive functioning that affects daily activities. And a lot of people think of Alzheimer's as the only dementia, but it isn't. It's the most common type, but it isn't the only type. And it's not a normal part of aging. It can be a symptom, dementia itself can be a symptom of many neurological conditions and can affect people of various ages. I just read an article yesterday where they have someone that they think it's the youngest diagnosis for Alzheimer ever diagnosed, a 19-year-old. So that just blew my mind. I'm sure it blew your mind too. But it's important to remember that dementia and delirium are two separate things. Dementia is permanent, delirium is temporary. So, confusion is not necessarily a sign of dementia. It can be caused by infections, especially urinary tract infections in the elderly, medications, alcohol, fever, depression, dietary deficiencies, and thyroid problems. So, it's not always dementia. There might be some other condition going on. You can't jump right on the dementia train. So the common symptoms are cognitive symptoms and motor and behavioral symptoms. So the cognitive symptoms include memory loss, confusion, problem-solving difficulties, and language problems. Motor and behavioral symptoms include motor planning problems, which is called apraxia, spatial dimensional dysfunction, and perseverative behavior, which is where you do the same thing over and over again, or say the same thing over and over again. So, Alzheimer's disease is one of the more common forms of dementia. It's a degenerative disease of the brain, and it affects the ability to form new memories because it affects the hippocampus, and that's where new memories are formed. Recall older memories because it affects the association areas of your brain, which is where memories are stored. Perform motor tasks, communicate, and perform self-care activities. So this is from the Alzheimer International Organization. The statistics about Alzheimer, the increased average lifespan correlates with the incident of Alzheimer. However, that doesn't mean that you're going to get Alzheimer when you get old. There's correlation, not causation. AD is the most common form of dementia, and it's important to recognize that it's not the only possible cause of dementia. But there are over 10 million new cases of dementia each year worldwide, implying one new case every 3.2 seconds. Doesn't that blow your mind? Blows my mind. So types of AD include familial, which accounts for about 5 to 10% of cases. Familial type is often referred to as early onset Alzheimer's. So the article that I read about the 19-year-old that just was recently diagnosed was diagnosed with this type of Alzheimer. It develops and progresses at much younger ages, usually in 50s and 60s, not at 19. That's very unusual. There are specific dominant genes that have been identified with familial types of Alzheimer disease. One subcategory of familial type Alzheimer's is associated with trisomy 21 or Down syndrome. So, and we'll talk about that next chapter. So sporadic Alzheimer is 90 to 95% of the cases, and there are at least 5 different subtypes. All of them develop in middle adulthood, and I don't know what age group they mean by middle adulthood, and they progress rapidly. So the causes and risk factors, although The actual cause is not known for sporadic AD. There has been a genetic link identified. So the risk factors include age, head injuries, depression, sleep deprivation, and hypertension. So hypertension is a risk factor for a lot of terrible things that you don't want to have. So keep your blood pressure under control. I always say I'd rather take a pill than have a stroke. I'd rather take a pill than develop Alzheimer too. So some studies have suggested that regular physical exercise, yay, mental exercise, education, reading, intellectual stimulation, yay, that's what we're doing right now. And a diet low in saturated fat and simple carbohydrates can help reduce the risk of Alzheimer. Let's hope that's true, okay? And do those things. And also, those things also help with other aspects of health. So, those are all good things to do. The way the symptoms progress, usually the progression is similar from person to person, but the rate varies. So that makes sense. Most people first notice short-term memory loss. And so it's not just forgetting where you parked your car. So one time I heard a doctor say, forgetting where you parked your car is normal. Forgetting that you have a car, that's a problem. So that's most people notice short term, like they can't remember what they had for lunch pretty consistently, or they have difficulty following the plot of a movie because of short-term memory is important in working memory in having conversations and following plot of a movie or a book. So first, that is the noticeable thing. Then motor skill and language difficulties. Then long-term memory loss and disorientation. And in the final stages, patients become not necessarily bedridden, but their mobility is severely compromised and unable to perform any self-care activities. People don't die of Alzheimer. They usually die from an infection, most often from a pressure injury or pneumonia. That's not good. So pneumonia is up there in the top 10 things that'll probably kill everybody. So there you go. Just secondary problems that develop from immobility. So the best thing we can do if we're working with people with dementia is to help keep them mobile. That's the best thing we can do for them. The changes in brain tissue include neurofibrillary tangles inside the neurons and amyloid plaques outside the neurons. There's a cool video, which I have a link to here, and I'm going to have you follow it. And it goes to an NIH page that is still on. And there's a link to this in the text, I think, too. Watch it now, because who knows how long those agency links are going to stay up. A lot of the CDC links are down now. But how the brain changes in Alzheimer, it's not very long. It's great. You should watch it. The interesting thing is they don't know. They initially thought that the changes were causing Alzheimer, but now they're thinking the changes are a result of the Alzheimer. So that you can go to the NIH website and check it out. This link is also in the chapter. So before the early 2000s, the molecular and cellular changes in brain tissue could only be seen under a microscope during an autopsy after death. Well, fat lot of good that does you, because you're already dead. But now we have advanced diagnostics that allow us to use imaging and biomarkers and blood tests to diagnose Alzheimer's disease. So brain PET scan imaging, so positron emission technology, and blood tests for biomarkers associated with dementia. So now you can get a definitive diagnosis that you have it. Not that there's a treatment for it, but hopefully that's coming. Hopefully. So all areas of the brain are affected. Notable changes occur in the hippocampus where memories are stored, memories are encoded, and the cerebral cortex, including the temporal lobe, parietal lobe, and frontal lobe, and in the cingulate gyrus. Those are all decision-making, executive decision, motor, processing, association cortex areas. There's an actual deterioration of the brain tissue in these areas, and the gyri which are the bumps on the cerebral cortex, become wider and shallower. The ventricles, which are the spaces in the brain where the cerebral spinal fluid is, become larger, leading to an overall decrease in brain tissue mass. So, if there was some way to weigh your brain before and after, it would weigh less after. The prognosis is there's no cure for Alzheimer. The medications used in the treatment of the disease do not affect the disease progression. They treat the symptoms. So people with Alzheimer live an average of 10 years after initial diagnosis with steadily declining abilities in cognition, communication, and motor skills. So despite the fact that there's no known cure, there's some promising research. So you know me, I like to read research, and um, there's always research going on and trying to understand the disease process. How does this happen? What happens to the cells? What's the pathophysiology? If they can figure out that, it's a little bit easier to get towards around how can we change that. So the development of new drugs and interventions that could help slow the progress or decrease symptoms and ultimately prevent or cure Alzheimer's, that's what we want. That's what research should be focused towards. The possible role of viruses and diabetes in the development of Alzheimer's is also being researched, so kind of interesting. Diabetes, of course, affects the microcirculation throughout your body, and so it wreaks havoc. So another type of dementia that is not as common as Alzheimer is Lewy body dementia. So Lewy bodies are abnormal deposits of a protein called alpha-synuclein in the brain. It's associated with changes in brain chemicals or neurotransmitters such as dopamine and acetylcholine. Um, it is classified as a movement disorder along with Parkinson's and some other syndromes because of the similar movement disorders. However, it is a different thing from Parkinson's disease. Just keep that in your mind. So the symptoms include cognitive decline, movement problems, and alterations in mood and behavior. I always think of Lewy body dementia as almost like being a cross between Alzheimer's and Parkinson's. So it's like you have the cognitive effects of Alzheimer and the motor effects of Parkinson. It's not a good combo. So for PTAs, we're going to see significant day-to-day variability in function. So we have to adapt treatment intensity and complexity based on their current cognitive and physical state. Fall risk is high due to movement and cognitive issues. I have worked with a few people with Lewy body dementia, and we work on movement therapy. Large amplitude movements have been helpful for people with Lewy body dementia. They and so you're not going to cure the disease, but you can help them move better and be safer. That's really what you want to do. It's a very interesting, it's interesting to work with people with Lewy body dementia. And one of my patients who had LBD, it gave me a lot of insight into what he went through getting diagnosed with it. He was a little earlier stage, but very interesting. So sometimes you see Lewy body and Parkinson together, but not always. Much more often not. Not all people with Lewy body dementia have Parkinson's disease, but they demonstrate Parkinsonianism, which is the characteristic movement patterns associated with Parkinson's disease. Tremor, bradykinesia, muscular rigidity. Remember TRAP? Yes, they have those things. So the the estimates say that Lewy body dementia represents 4 to 16% of cases of dementia seen in the clinic, but they don't really know. So that's an estimate, and that's from the Lewy body dementia organization. So a lot of times when you're looking up information like for a project, which you don't have in this class, but in the future, for a project, the organization of the individual diseases are great sources of information, and a lot of them have like a research clearinghouse, so you can see research about that disease. So just a tip. So distinguishing Lewy body dementia from other forms of dementia, usually it doesn't start with memory problems like Alzheimer does. Cognitive problems develop later, and they include um, attention deficits, visual and spatial ability problems, planning problems, difficulty multitasking, problem solving, and reasoning. And the cognitive functions fluctuate. So people have good days and bad days. Hallucinations are more common in Lewy body dementia than in other forms of dementia. So that's kind of interesting. And I have had patients tell me some really interesting hallucinations that they had. Sleep disturbances are common with most forms of dementia, and mood changes, including depression, anxiety, agitation, delusions, and paranoia, are common with Lewy body. So other problems, and this is true for Parkinson's as well, autonomic regulation disorders, changes in body temperature, changes in blood pressure, dizziness, and falls, mostly because of the changes in blood pressure, orthostatic hypotension, and urinary incontinence. So there's no cure for Lewy body dementia. There are medications which might help slow disease progression. Maybe, maybe not. Okay. Vascular dementia is where the brain does not receive adequate oxygen, and you get damaged brain tissue. And one of those results can be dementia. So a common cause of this type of dementia is a stroke. So you had a stroke and areas of your brain died, and it caused dementia later on. So as you know, strokes are highly variable depending on which brain tissues are damaged. And so vascular dementia doesn't develop in everybody who's had a stroke, and actually very few people. Alzheimer's disease can also cause people to develop vascular dementia, interestingly enough, as if they didn't have enough things. So even small clots in the arteries and capillaries can cause vascular dementia if there are enough of them. So the risk factors are age, stroke, if you've had a stroke, or TIAs, transient ischemic attacks. Some people call those mini strokes. Heart attack, diabetes, hypertension, all the bad boys. High cholesterol, smoking, there's smoking again, atrial fibrillation, and obesity. So people with vascular inflammation and potential for blood clots like PVD, atherosclerosis, hypertension, diabetes, anyone who has those things is at risk for vascular dementia eventually. So, so many people that we treat have these cardiovascular risk factors. So be aware, especially if you have a long-term patient, that cognitive changes might develop, and focus on cardiovascular health in your treatment when it is appropriate and part of the plan of care. So the symptoms of and treatment of vascular dementia. So the symptoms are problems with reasoning, planning, judgment, memory, and other cognitive function, just like the other forms of dementia. So the area of the brain that was deprived of oxygen or anoxic is the most important factor in determining the exact symptoms. So this is interesting. The functional or the functional MRI screen. I think it's functional MRI of the non-affected brains are on the left, and the vascular and Alzheimer's are on the right. Kind of interesting. So there's no cure for vascular dementia. The diagnosis is generally made by clinical presentation and supported by CT or MRI. There, a lot of times they'll use blood thinners or anticoagulants to help prevent future clots. Sometimes platelet medications that prevent platelets from adhering to prevent future clots, to make it not, it doesn't cure it, but it doesn't, it hopefully slows the progression, doesn't make it worse. So for whatever form of dementia we're talking about, the treatment goals are to maintain communication abilities as much as possible, preserve personal interaction, maintain physical abilities as much as possible, promote independence as long as possible. And currently, there aren't any cures available, but treatments can help manage symptoms. So I worked with a lady years ago who had Alzheimer's, and she had been a rockette, a Radio City Music Hall rockette when she was young. So she was a dancer. It was really interesting. And she didn't tell me that, but her family told me that. And if you put on music, she always responded to it. If you wanted her to go faster on the new step, put on music and she would go to the beat of the music. When you got her in the parallel bar, she remembered all the ballet positions. and she would just do them. It was so cool. But, music is a lovely intervention that you might use. Medical interventions include um, drugs for symptom management, antidepressants, anti-anxiety medications, sleep aids. A lot of times people with dementia do what they call sundowning, where they sleep during the day and they're up at night. Parkinson's disease medications, if it's appropriate for their form of dementia. Blood thinners for vascular dementia. So supportive care, it could be living arrangements in just that they live at home or with family and they have accessible, safe home modifications and in-home care services. There are memory care facilities where people can go to get uh, cared for, and they have people who are specifically trained in memory care. Family and caregiver support is really important. Physical therapy is important for maintaining mobility, preventing falls, helping the people adapt their environments for safety, and exercise might help slow cognitive decline and improve quality of life. So the I guess the takeaway is we don't just give up on people. We try to help them maintain mobility and safety and adapt their environment as much as possible so they can have the best quality of life they can have. So there's a YouTube video which is really good about the types of dementia that you may watch. And it's really interesting. No matter what setting you work in PT, you will work with at least one person, if not many more, who have dementia.